Institute of Optometry, I extend a warm welcome to each and every one of you for the 9th episode of Optometry Series 2.0. I'm very happy to welcome my team members, Miss Meenakshi. Hi, Meenakshi. And Miss Anshika, ma'am. Hi, ma'am. Thank you so much for joining, ma'am. I'm very happy to welcome our today's moderator, Mr. Anush, sir. Hi, Anush, sir. Thank you so much for joining with us today, sir.
Thank you, ma'am. Thank you.
To know more about Anush, sir, and our today's moderator, I am passing down the mic to Ms. Madhuvina, the MC for the day.
Good evening, sir. Good evening, one and all. I am Madhuvina, studying third year bachelor's in optometry at Dr. Agarwal Institute of Optometry. It gave me immense joy to welcome today monitor Mr. Anush Nayak. Anush Nayak sir completed his bachelor's and master's in optometry from Manipal Academy of Higher Education, followed by clinical internship at LV Prasant Eye Institute. Sir is a committed and accomplished optometry professional, currently serving as an assistant professor in the Department of Allied Health Science at Ramaya University of Applied Health Science, Bangalore. Currently, he is also a PhD scholar at the same university, focusing his research on experimental glaucoma models. With a strong foundation in both clinical and academic domains, Sir brings a unique blend of practical experience and research expertise to the field of optometry. Sir has 5 publications to his name. His current research focus lies in understanding cellular changes, particularly in Muller cells and retinal ganglion cells, in experimental glaucoma models, reflecting his deep interest in advancing knowledge in the area of glaucomatous neurodegeneration. We are happy to have with you, sir, today. Thank you for so much for joining, sir. The presenter for today is Ms. Harini, third year bachelor's in optometry student at Dr. Agarwal Institute of Optometry. Please start your presentation, Harini.
Thank you, Madhuvina, for a good introduction. And I also thank all the optometry team for giving me a chance to moderate this session. Yes.
Today we are going to discuss about anatomy, physiology and diseases of sclera. Embryological development of the sclera. The sclera develops from mesodermal mesenchyme surrounding the optic duct. Development begins around the 6th week gestation. By the 7th to 8th week, scleral condensation is begun. Initially transparent, the sclera becomes opaque as collagen fibers mature and organize irregularly. It is fully developed by birth, though it remains thin and may appear blue-tinted in women. Continuation of embryological development of sclera. Postnatal development continues to thicken and strengthen during early childhood and adolescence. Its rigidity increases with age. A clinical note in disorders like osteogenesis imperfecta, the sclera remains thin and translucent, leading to the sclera. Anatomy of sclera. The sclera is the dense, white, fibrous outer coat of the eyeball that maintains the shape and integrity of the eye. It's opaque, unlike a transparent cornea, due to irregularly arranged collagen fibers and no water content. Shapes of the posterior 5/6 of the outer cubic of the eye. The cornea occupies the anterior 1/6. Acts as a protective barrier for internal ocular structures, shielding them from trauma and external forces. The term white of the eye refers to the visible anterior portion of the sclera surrounding the cornea. It's covered externally by the non-structured and conjunctiva, internally by adjacent to the forehead posteriorly and ciliary body anteriorly. Shape and size. It's the part of roughly spherical shell contributing to the blue spot. Radius of curvature is approximately 12 mm, slightly flatter than the cornea. Its radius is approximately 8 mm. Dimensions are antero-posterior length of the globe is approximately 20.
Arnie, we couldn't hear you. Just a minute.
Extent and boundaries. Anteriorly, it emerges with the cornea at the limbus. Posteriorly, extends to the optic nerve, ending at the lamina cribrosa within the posterior scleral foramen and laterally provides attachment for extraocular muscles. Thickness. It is thickest at the posterior pole, approximately 1 mm, offers strong structural support. Thinnest just behind the insertion of rectus muscle, approximately 0.3 mm, at an area prone to globe rupture in trauma. At limbus, it is approximately 0.8 mm. Its thickness at equator is about 0.4 mm to 0.6 mm. Thickness gradually decreases from the posterior pole towards the equator and anteriorly towards the limbus. Color and appearance of sclera. It appears white in adults due to dense, irregular collagen and minimal vascularity. May appear bluish in children due to thinner sclera revealing underlying uveal pigment. It may look yellowish with age or in systemic conditions like jaundice. Layers of sclera. It has 3 layers. The first layer of sclera is episclera. It's the outermost layer. It's made of loose vascular connective tissue. It's rich in capillaries, especially anteriorly. Lies between Tennant's capsule and the scleral stroma. Response in episcleritis with localized inflammation. Scleral stroma is the second part of sclera. Middle and thickest layer, it is composed of irregularly arranged collagen bundles, providing tensile strength and rigidity. It contains a few fibroblasts and proteoglycans. Appears opaque due to the disorganized collagen and low water content. Avascular gets nourishment but adjacent layers. Lamina fusca is the innermost layer of sclera. It is adjacent to the choroid and ciliary body. It contains pigmented melanocytes, giving it a brownish appearance. It facilitates smooth transition between sclera and uveal tissue, allows passage of short ciliary nerves and vessels. Composition of sclera. Collagen makes up about 90% of scleral content arranged irregularly to provide opacity and strength. Elastic fibers present in small quantities provide limited flexibility. Proteoglycans bind water and help in spacing collagen fibrils. Fibroblasts, the main cellular components involved in synthesis and maintenance of collagen and extracellular matrix. Water content is lower than the cornea, approximately 65% versus approximately 78%, contributing to non-transparency. Unlike the cornea, no regular lattice arrangements making it opaque. Scleral openings. Anterior scleral opening. Scleral foramen. A circular opening at the front of the sclera where the cornea is inserted, also known as limbal region. It marks the transition between opaque sclera and transparent cornea. Second opening is posterior scleral foramen. Large opening at the back of the sclera. It allows passage of the optic nerve fibers. It's filled by lamina cribrosa, a sieve-like structure through which optic nerve axons exit the loop. Canals and emissary pathway. Canal of Schlem. It is located in the limbal region, plays a key role in aqueous humor drainage into the episcleral veins, connected to the anterior chamber via trabecular meshwork. Emissary canals are tiny channels for blood vessels and nerves to pass through the sclera. It includes vortex veins, ciliary arteries and nerves, and lymphatics and scleral nerves. Blood supply of the sclera. Episclera is the vascular layer. It's rich in vascular network mainly supplied by anterior ciliary arteries and long posterior ciliary arteries. These vessels form this episcleral arterial circle near the limbus. Scleral stroma is a avascular structure, contains no blood vessels within the stroma itself. Nourishment is provided by diffusion from the episcleral vasculature externally, diffusion from the choroidal vessels internally, aqueous humor anteriorly near the limbus. Innervation of the sclera. Sensory innervation is provided by short ciliary nerves and long ciliary nerves. These nerves pierce the sclera around the optic nerve and pass forward between the sclera and choroid. Pain sensitivity of sclera is highly pain sensitive.
sensitive, especially in scleritis. Deep boring eye pain in scleritis is due to stretching of the nerve endings within the sclera. Pain that worsens at night or with eye movement can be a sign of posterior scleritis. Physiology of sclera. It provides structural support by maintaining the shape and integrity of the eyeball. It offers protection to internal ocular structures from physical trauma and external insults. It serves as the site of insertion for the extraocular muscles, allowing for the sclera helps resist IOP, preventing the globe from expanding or deforming. It plays a role in maintaining the axial alignment of the cornea, lens, and retina, which is essential for the clear retina. Inflammatory disorders. Episcleritis. It's a benign recurrent inflammation of the episclera involving Tennant's capsule, sparing the scleral tissue itself. Epidemiology. It's a more common in young adults, especially females, 2:1 female to male ratio. Self-limiting and non-vision threatening. Etiology of episcleritis. It's idiopathic. It is most common. Associated systemic diseases are gout, rosacea, psoriasis, and connective tissue diseases. Hypersensitivity reaction to endogenous trabecular and streptococcal antigens. Infectious causes are herpes zoster, syphilis, Lyme disease, and tuberculosis. Pathophysiology. There is a localized infiltration of lymphocytes indicating a cell-mediated immune response. The episcleral vessels become dilated and congested, leading to visible redness and localized edema. Edema and vascular congestion extended to overlying Tennant's capsule and conjunctiva, causing mild swelling and discomfort. Unlike scleritis, the inflammation in episcleritis is superficial and scleral stroma is not involved. Symptoms. Sectoral or diffuse redness can be seen, mild discomfort, minimal photophobia, occasional tearing can be experienced by the patient. It may be asymptomatic. Signs are, there are two types. Simple episcleritis and nodular episcleritis. In simple episcleritis, sectoral or diffuse inflammation, radially arranged episcleral vessels can be seen. In nodular episcleritis, discrete mobile tender nodule located approximately 2 to 3 mm from the limbus. These are the photos. Differential diagnosis. Simple conjunctivitis, nodular inflamed pengicula, conjunctival foreign body, early scleritis. Treatments are topical NSAIDs like ketorolac 0.3%, topical corticosteroids like fluorometharon, loteprednol, lubricants like carboxymethyl cellulose, cold compresses, and oral NSAIDs can be prescribed. Scleritis, severe, potentially sight-threatening inflammation of the sclera proper. Epidemiology is uncommon compared to episcleritis. Common in 4th to 7th decade, more in females. Can cause vision loss or globe perforation. Etiology. It's an autoimmune disease, most commonly RA, SLE, PAN, Wegener's, ankylosing spondylitis. Metabolic gout, thyrotoxicosis. Infectious, herpes zoster, staphylococcus, streptococcus, TB, syphilis, leprosy. Granulomatous conditions, sarcoidosis, syphilis, TB. Miscellaneous chemical burn, irradiation, VKH, PACETs. Surgically induced within 6 months post-op. Pathophysiology is, it is chronic granulomatous inflammation, involves the immune-mediated reaction, then causes persistent tissue damage. There is fibrinoid necrosis of the sclera collagen, resulting in loss of structural integrity. Inflammatory infiltrates includes polymorphonuclear leukocytes, lymphocytes, plasma cells, and macrophages. Formation of multinucleated giant cells is seen especially in granulomatous forms. Vasculitis of sclera and episcleral vessels leads to ischemic and progressive collagen degradation, causing scleral thinning and, in severe cases, necrosis. Classification. Scleritis is classified into two types, infectious and non-infectious. Non-infectious is further divided into anterior and posterior. Anterior is divided into anterior non-necrotizing, diffuse and nodular, necrotizing with inflammation and without inflammation, which is also known as scleromalacia perforans. Clinical features. Symptoms are severe, deep, boring pain may radiate to jaw to temple. Pain worse at night or early morning. Redness, photophobia, tearing can be experienced. Visual disturbance possible. Anterior non-necrotizing diffuse scleritis. It is characterized by widespread inflammation involving either a segment of the globe or entire anterior sclera. It's relatively benign and rarely progresses to the nodular type. Anterior non-necrotizing nodular scleritis. On detailed examination, it may resemble nodular episcleritis. However, a more detailed evaluation shows that the scleral nodule cannot be moved over the underlying tissue. The natural history of nodular scleritis suggests that it's a disease of intermediate severity and the patient should be monitored for occasional development and subsequent scleral necrosis. Anterior necrotizing scleritis with inflammation. It is the most severe form of scleritis with a gradual onset of pain and localized redness. Its clinical features includes occlusion of vessels seen in affected area with vascular patches appearing in the episcleral tissue followed by development of scleral necrosis. Eventually, sclera becomes transparent and the underlying uvea is visible. The inflamed area gradually spread around the globe. Anterior necrotizing scleritis without inflammation. It typically occurs in women with long-standing seropositive rheumatoid arthritis. The condition is asymptomatic and starts with the yellow necrotic scleral patches in normal sclera. Unless the IOP is elevated, spontaneous perforation is extremely rare. There is no effective treatment. Posterior scleritis. It's defined as scleral inflammation primarily arising posterior to the equator. The most common presenting symptoms are pain and visual impairment. Its signs are ophthalmoscopy frequently shows disc swelling, macular edema, and exudative retinal detachment. Other posterior signs include vitritis, ring choroidal detachment, choroidal folds, subretinal mass, intraretinal white deposits resembling hard exudates and subretinal exudations. Signs. Non-infectious anterior scleritis. Diffuse type is most common sectoral or widespread inflammation with violaceous hue. Nodular type is firm, immobile nodules near the limbus. Necrotizing with inflammation is local scleral necrosis, uveal show associated with uveitis. Necrotizing without inflammation, also known as scleromalacia perforans, is planeless scleral thinning in elderly females with RA. Posterior scleritis. Often misdiagnosed exudative retinal detachments, macular edema, proptosis, restricted ocular movements can be seen. In, in infectious scleritis, purulent discharge or exudates, fistula formation, scleral ulcers, early stages may mimic non-infectious scleritis. Complications includes sclerosing keratitis, corneal melt, cataract, secondary glaucoma. Investigations are CBC, ESR, DLC to detect seismic inflammation or infection. Rheumatoid factor, ANA, LE cells to assess for underlying autoimmune or connective tissue diseases. Syphilis serology to rule out syphilitic scleritis. Serum uric acid to detect hyperuricemia or gout-associated scleritis. Urinalysis used to screen for systemic conditions like lupus nephritis. Mantoux test to rule out tuberculosis as an infectious cause. X-ray to identify systemic granulomatous disease or foreign body in nodular scleritis. Treatments include for non-infectious, non-necrotizing, topical corticosteroids and oral NSAIDs can be given. For non-infectious, necrotizing, systemic corticosteroids, immunosuppressants, scleral patch grafts, and subconjunctival scleral contraindicated. Steroids contraindicated. Infectious, uh, for infectious, avoid steroids initially. Aggressive targeted antimicrobial therapy. Surgical debridement may be required for drug penetration. Blue sclera. It's an asymptomatic blue appearance of sclera due to thinning, allowing uveal pigment to show through. It is associated with osteogenesis imperfecta. Ehlers-Danlos syndrome, Marfan syndrome, pseudoxanthoma elasticum, ophthalmos, and high myopia. Staphylomas or outpouching of thinned outer layer coat lined by uveal tissue. Its types includes anterior, intercalary, ciliary, equatorial, posterior. Anteriorly, it is located in cornea and post-infective thinning. It's caused by corneal ulcer perforation. Intercalary is located in limbus, limbal ectasia. It is caused by healed trauma and corneal ulcers. Ciliary staphylomas are located in 2 to 3 mm from limbus, lined by ciliary body. It is caused by scleritis, trauma, glaucoma. Equatorial staphylomas located at equator, lined by choroid. It is caused by pathologic myopia, scleritis. Posterior staphylomas located behind equator. It is seen in ophthalmoscopy, caused by high myopia and posterior. Management. It is depend on cause. Staphylectomy may be needed in anterior or intercalary types. Managed underlying inflammation or systemic diseases. These are the references. Thank you.
Thank you so much, Harini. It was a very good presentation, and your presentation had almost all the contents necessary for today's topic. Now, I request the moderator to add your valuable clinical inputs, sir.
Yes, thanks, Harini. I think it was a good presentation. I think you have covered most of the topics. Uh, yeah, I think lot of insights on anatomy, physiology, and diseases as well. So one thing what I can add is, yes, as you stressed, I think in the two slides you have mentioned about osteogenesis imperfecta. I think that is one of the important systemic disease here, because that is one of the connective tissue disorder where it affects the collagen fibrils, and that is why we see a lot of eye related changes like blue sclera, as you mentioned, and we also see thin cornea and some rare cases lens subluxation, also retinal detachment also in rare cases we do see that. And I don't know if you had mentioned, I think rheumatoid arthritis also plays an important role here, because rheumatoid arthritis also, we see episcleritis and scleritis to an extent. So probably that, probably could have stressed on rheumatoid arthritis as well. I think overall it was good. So probably I think anatomy and physiology is covered. So I would like to give a little bit insights on what is currently happening in sclera, because now there are a lot of research which is happening in sclera. One such research which is very important is, in terms of ocular biometry, there is a lot of focus on iris, but now they have focused on deep vessels on sclera. So they're seeing the scleral vessels changes, and they're trying to frame something on ocular biometry. So that is one of the important projects which is happening. And when it comes to optometry related projects, I think myopia control and sclera plays a very good role here. So they have seen, they're trying to see, in terms of myopia, how is the sclera changing and what is the mechanics which is changing that, and how does our myopia control lenses affect on sclera. That is one thing what is there. And also in general, like anemia, diagnosis of anemia also, there are some researches which is happening, and they're trying to see changes in sclera as well. So I think there are a lot of research opportunities when it comes to sclera also. So this is some of the insights what I wanted to add on. Thank you.
Thank you so much, sir. And we also have certain questions from our student side. I'll read it for you.
Sure. Yeah.
The first question is, clinically, how do we differentiate between scleritis and episcleritis?
Okay. So we have one test. Yes, I forgot to tell about this. So we have one test. We call it as a phenylephrine test. So what happens is, in both the cases, the vessels will be dilated. So when we add this phenylephrine content, if it is an episcleritis, the redness goes away immediately. So, and if it is a scleritis, the redness stays like that only. So this is also one of the key point where optometrist has to take care is, usually in a workup, once we start with the vision and once we do till the dilatation, because majority of the institutes, this is the protocol, like we dilate the eyes and then the doctor sees the retina. So sometimes when the patient is complaining that, patient has on and off redness, or there is a redness early morning, so we need to note it down before we dilate the patient, because usually we dilate with T plus, tropicamide plus. So it has a phenylephrine content. So the moment we put this, the redness goes away. So once the doctor sees, the redness might not be there. So that can be a, drawback that we have to diagnose it first. Before we have to document it that there was a redness, then a T plus is added, because the redness goes away. So the main differentiating factor is phenylephrine. And when it comes to the symptom wise, probably scleritis has more pain than, there will be a very mild discomfort. Like in episcleritis, you cannot call it as a pain, but scleritis has more pain. Yeah.
Thank you so much, sir. Second question is, what is the optometrist role in diagnosing scleral diseases?
Yeah, see, that's what, yeah, probably there is no much role. Okay, but that's what, as I said, initially when the patient comes with the typical complaint of redness, and when we dilate the patient without, we let's assume that we don't know about episcleritis, scleritis, and we directly dilated the patient. So we are not valuing the patient's complaint. So the role is over here. So diagnosing earlier is better, so or else patient has to come again once the redness reoccurs. So it is better that, we have to know this. So optometry role, I would say that, more than diagnosing, yes, diagnostic there is a role, but more than diagnostic, I think research is the thing what we have to look in, because there are a lot of research openings which are happening in sclera. Okay, I think I didn't mention on that. So there is one particular thing what people are looking at is CSR, central serous retinopathy, where they are seeing changes in choroid also. So they are also tying up with sclera. So I think research-wise, there is a very good opportunity when it comes to sclera, more than, diagnostic. Yes, diagnosis is also important, but research plays a major role over here.
Thank you so much, sir. We saw many systemic conditions associated with scleritis or episcleritis. So, in case of history taking, what kind of history has to be asked in case of ruling out scleritis or episcleritis?
Yes. Yeah. So majorly, I would say that systemic disease, yes, it is very important. But probably, I think the two major systemic disease what plays a role here is one is rheumatoid arthritis, because rheumatoid arthritis is seen in cases of scleritis, episcleritis, and also dry eyes also. And I think we can ask on anything which is connective tissue related diseases, osteogenesis imperfecta, or anything which is connective tissue disorder, because in our sclera we have mainly collagen bundles. So I think it is better to ask any disease which is associated with connective tissues.
Thank you so much, sir.
Yeah.
That is all with the questions. Anshi ma'am, do we have questions for moderator ma'am?
No, it was a good session. So I just want to add to what Anush also said that currently a lot of research has been going on in sclera, and a few things which I would like to mention is redness, blue tinge, yellow tinge are few things which we should actually look as an optom when we are seeing the patients. So as rightly said, it might not be important that we're not diagnosing the condition, but that white canvas, which is the sclera, helps us in diagnosing a lot of conditions, and especially it takes care of because it involves systemic conditions also. So it is important that as an optom we don't miss out on it. So thank you so much, Harini and Anush, for spending so much of time. It
Thank
was
you, ma'am.
really
Thank you
very
so
nice
much.
interaction. I'll handing over to Gomati.
Sure. Thank you.
Thank you so much, Anshika ma'am. Meenakshi, thank you so much. Harni, that was a wonderful presentation, dear. And Anush sir, thank you so much for joining with us. We'd like to host you on another wonderful platform, sir.
Thank you, madam. Thank you, and thank you for entire optometry team at Agarwal for giving us an opportunity. So this is a very good platform where externals also meet. So we do also get to know people. So thank you for inviting me.
Thank you, sir. Thank you so much. We have certain announcements to make, sir. We'll make the announcements.
Sure.
Yes, thank you. So ISV Tech, so as you all know, ISV Tech, which is a collaborative conference with the Loyola College, is happening on 24th and 25th October. Early bird registration is closing on 15th August 2025. So colleges, faculties, academicians, everybody can pitch in to know more about what are the happenings that is happening with the AI integration in the eye care. So which is happening on 24th and 25th. So block your dates for the conference. The second announcement is I'm very happy to welcome the new batch of Masters in Optometry students. Anshika ma'am, how's the new team of students, ma'am?
They're still settling down. They're good. We are still expecting more. So waiting.
Yes. With bachelor's and master's in optometry, the admissions are open for fellowship and internship in optometry pan India level. So anybody who wanted to have admission or who wanted to make inquiries, you can check for the contact number in the description box. Meet you all in the next episode. Thank you, team. Thank you so much. Thank you, Anush sir.
Thank you all. Thank you.
Thank you so much, Anushwar, for joining.
Thank you, madam. Thank you.